Hello everyone and welcome to my presentation. As you can see on the screen, our topic today is vitamin D deficiency and cardiovascular diseases. First of all, I would like to talk about the definition of vitamin D and cardiovascular diseases. Vitamin D is a fat-soluble vitamin that is naturally present in a few foods, as to others, and available as a dietary supplement. It is also produced endogenously when ultraviolet rays from sunlight strike the skin and trigger vitamin synthesis. Vitamin D was initially characterized as a factor capable of curing rickets, a disease characterized by bone demineralization and skeletal deformities. Vitamin D exists in two forms, vitamin D3 or cholecalciferol and vitamin D2 or ergocalciferol. Cardiovascular disease is a disease related to heart and blood vessels, veins, and arteries. According to cardiovascular disease, I would like to define three words: coronary artery disease, myocardial infarction, and left ventricular hypertrophy. Coronary artery disease is narrowing of the arteries of the heart, which causes a reduction of blood flow. Myocardial infarction is a blockage of one or more of the coronary arteries, causing lack of oxygen to the heart and death of the muscle tissue. Left ventricle is the left lower chamber of the heart, which pumps oxygenated blood through the body. It is the biggest and strongest chamber, known as the workhorse of the heart. So, left ventricular hypertrophy is a term for a heart's left pumping chamber that has thickened and may not be pumping efficiently. According to my topic of presentation, I would like to know how does vitamin D deficiency associate with cardiovascular diseases. I would like to give you the first article, Association of Vitamin D Deficiency and Degree of Coronary Artery Disease in Cardiac Patients with Type 2 Diabetes. Type 2 diabetes mellitus is related to many complications, including macroangiopathy, and it is known to be one of the main risk factors for coronary disease. The pathogenesis of diabetes is multifactorial, and the process of glycemic control is very complex. As such, the role of vitamin D deficiency has been recently suggested. Vitamin D via regulation of calcium influences various mechanisms associated with the pathophysiology of type 2 diabetes mellitus, including pancreatic beta cell dysfunction and impaired insulin action. The previous studies showed that optimizing vitamin D level could reduce insulin resistance, improve glycemic control, and consequently reduce the risk of type 2 diabetes mellitus. Vitamin D deficiency is considered a so-called non-classical cardiovascular risk factor. It was shown that low 25-hydroxy vitamin D level was associated with prevalent coronary artery disease, independent of other recognized cardiovascular risk factors. The previous research showed that patients with low level of 25-hydroxy vitamin D less than 21 nanogram per milliliter have an increased risk of, for example, hypertension, diabetes, and obesity. So the patient study focused on the association between the 25-hydroxy vitamin D level and the severity of coronary artery atherosclerosis in cardiac patients with type 2 diabetes. Next, I will focus on the methods. The study was performed in 337 consecutive patients undergoing coronarography. Coronary angiography performed due to suspected coronary artery disease was the sole inclusion criteria for the study. Data were collected using an interview questionnaire, age, ethnicity, smoking habits, and etc. Electric vitamin D total assay was used for the quantitative determination of total 25-hydroxy vitamin D, the major storage form of vitamin D in the body, in patients' serum and plasma. This competitive electrochemiluminescence assay evaluates the levels of both 25-hydroxy vitamin D2 and 3. The coronary artery surgery study score, or CASSS, was used to assess the degree of coronary atherosclerosis. The score may illustrate 1, 2, or 3 vessel CAD. The statistical analysis were performed with a significant level of 5%. The results show that patients without significant lesions in coronary arteries presented the higher 25-hydroxy vitamin D level, significantly higher than patients with 1, 2, and 3 vessel coronary artery disease. Patients with CASSS0 presented significantly higher median 25-hydroxy vitamin D value than patients in all other CASSS subgroups, that is, form 1, 2, 3. The results show a statistical significance in the prevalence of patients divided according to sex, CAD status, and previous myocardial infarction among CASSS subgroups. Due to significant differences in the 25-hydroxy vitamin D level among patients with CASSS0 and CASSS form 1 to 3, the overall group was divided into two subgroups: patients without significant stenosis in any of the large epicardial coronary arteries, and patients with significant stenosis in 1, 2, and or 3 coronary arteries. There were significant differences in sex, 25-hydroxy vitamin D, CAD status, and previous myocardial infarction. From selected variables, sex, 25-hydroxy vitamin D, and previous myocardial infarction proved to be significant determinants of CASSS. Patients with ACS presented significantly lower values of 25-hydroxy vitamin D than patients with stable CAD. There was a statistical significance in the prevalence of patients in the subgroups of CASSS, and there was statistical significance in the prevalence of patients divided according to smoking habits, previous myocardial infarction, and examination data among two groups of CAD status. Lower 25-hydroxy vitamin D levels were observed in patients with the history of myocardial infarction in comparison to patients without previous myocardial infarction. In the logistic regression analysis, from selected determinant, a history of previous myocardial infarction and examination data were statistically significant. the presence of hyperlipidemia, history of previous myocardial infarction, and examination between November and April were significantly associated with lower values of 25-hydroxy vitamin D in cardiac patients with diabetes. For the discussion, in this study, the association between 25-hydroxy vitamin D level and the severity of coronary atherosclerosis was clearly observed. That is, the results show that diabetic cardiac patients with CASSS0 presented a significantly higher vitamin D level in comparison to patients with 1, 2, and 3 vessel coronary atherosclerosis. Patients with an extreme form of coronary artery disease have the lowest values of 25-hydroxy vitamin D. The history of previous myocardial infarction was significantly and independently associated with both higher number of vessels with significant stenosis and a lower vitamin D level. A significantly lower 25-hydroxy vitamin D level was also noticed in diabetic subjects hospitalized due to ACS compared to patients diagnosed with stable CAD. Multiple studies suggested that hypovitaminosis D is associated with an increased risk of cardiovascular diseases and diabetes. Coronary artery disease is the most common complication of diabetes and the leading cause of death in this group of patients. The lower values of 25-hydroxy vitamin D concentration is this study in comparison to other studies may be associated with the method of vitamin D measurement. Elexis vitamin D total assay was used in these patients to determine the total 25-hydroxy vitamin D level. The other researcher stated that the large Elexis vitamin D3 assay presented unacceptable performance and thus underestimated vitamin D level. The low level of vitamin D in cardiac diabetic patients may be one of many factors leading to the destabilization of atherosclerotic plaque and, in consequence, to the local formation of blood clot and subsequent myocardial infarction. In addition to a thin connective tissue layer on the surface of the plaque, large lipid nucleus, excessive inflammatory response, and increased neovascularization play a key role in the process of the destabilization of atherosclerotic plaque. The results presenting the relationship between low levels of 25-hydroxy vitamin D with myocardial infarction in patients with significant stenosis in coronary arteries and type 2 diabetes are consistent with other published data. Although the definition of vitamin D deficiency differs in various studies, it was shown that a low level of 25-hydroxy vitamin D in diabetic patients is related to an increased number of multi-vessel lesions, a higher risk of cardiac nosocomial death, a higher risk of asymptomatic CAD, a poor glycemic control, and a higher serum level of inflammatory markers. The results discussed above together with these findings suggest that there is an association between a low level of vitamin D and a stage of coronary artery disease expresses as the number of stenotic coronary arteries in cardiac patients with type 2 diabetes mellitus, particularly in patients hospitalized due to ACS with a history of previous myocardial infarction and hyperlipidemia. Taking into account factors associated with the number of coronary arteries with significant stenosis and a determined level of 25-hydroxy-vitamin D, the researchers identify a group of cardiac patients with diabetes who may be mostly predisposed to vitamin D supplementation. Such a group consists of male patients with significant stenosis in 3 coronary arteries, hospitalized due to acute coronary syndrome with a history of previous myocardial infarction and hyperlipidemia. However, this study is observational, thus it cannot determine the impact of intervention such as vitamin D supplementation and/or exposure to summer sun on, for example, the degree of coronary atherosclerosis in diabetic cardiac patients. In conclusion, in cardiac patients with diabetes, the higher number of stenotic coronary arteries is associated with lower values of the 25-hydroxy-vitamin D. A group of male cardiac patients with diabetes with significant stenosis in 3 coronary arteries, hospitalized due to acute coronary syndrome with a history of previous myocardial infarction and hyperlipidemia presented the lowest vitamin D level. Next, I would like to talk with the second article. Lower serum 25-hydroxy-vitamin D level is associated with impaired myocardial performance and left ventricle hypertrophy in newly diagnosed hypertensive patients. Hypertension is an established major independent risk factor for cardiovascular disease. Furthermore, vitamin D deficiency is independently associated with cardiovascular morbidity and mortality in the general population and hypertensive patients. Lower serum 25-hydroxy-vitamin D levels are associated with a higher prevalence of hypertension. Moreover, vitamin D suppresses the renin-angiotensin-aldosterone system, which has an effect on blood pressure. Vitamin D receptors are found in many cells of the cardiovascular system. Vitamin D affects left ventricular structure by increasing left ventricle mass and myocardial contractility by affecting calcium flux and calcium homeostasis. Left ventricle myocardial performance index combines the indexes of contraction and relaxation in an overall index of left ventricle function. So, the purpose of this study was to investigate the association between 25-hydroxy-vitamin D and myocardial performance index and left ventricle hypertrophy in newly diagnosed hypertensive patients. The study hypothesized that vitamin D level may be associated with left ventricle function and geometry. Next, I focus on the methods. 151 sequential patients with newly diagnosed essential hypertension were included in the study. None of patients was taking calcium or vitamin D supplements. The patients were divided into two groups according to serum 25 hydroxy vitamin D level. Vitamin D non-deficient group that vitamin D level is equal or higher than 20 nanogram per milliliter, and vitamin D deficient group that vitamin D level is less than 20 nanogram per milliliter. Blood samples including glucose, creatinine, triglyceride, and total cholesterol, and HDL, LDL, high sensitivity, C-reactive protein, serum calcium, and parathyroid hormone were measured. The level of serum 25-hydroxy vitamin D was measured by using a direct competitive chemiluminescence immunoassay. In this study, 20 nanogram per milliliter 25-hydroxy vitamin D was used as a cutoff for vitamin D sufficiency, according to the recommendations from the WHO and more recently, the Institute of Medicine. Transthoracic echocardiographic examination was performed in the left lateral position. Standard two-dimensional and Doppler echocardiographies were performed using a commercially available echocardiography machine. The study also evaluated tissue Doppler and calculation of the tissue Doppler, the Live Myocardial Performance Index. The tissue Doppler of the mitral annulus movement was obtained from the apical four-chamber view. Myocardial Performance Index was defined as the sum of isovolumic contraction and relaxation times divided by the ejection time. Left ventricle mass index was calculated by using the Devereaux formula and body surface area. All analyses were conducted using SPSS, and a p-value less than 0.05 was considered statistically significant. The results showed that the median serum 25-hydroxy vitamin D value was 14.35 nanogram per milliliter. The vitamin D concentrations measured in winter were similar to in spring-summer in patients. Total cholesterol and LDL level was significantly higher in patients who were vitamin D non-deficient compared with patients who were vitamin D deficient. Creatinine and parathyroid hormone levels were significantly lower in patients who were vitamin D non-deficient compared with patients who were vitamin D deficient. Left ventricle ejection fraction and left ventricle diameter were similar between groups. However, patients who were vitamin D deficient had higher values of interventricular septal thickness, posterior wall thickness, left ventricle mass index, tissue Doppler isovolumic relaxation time, tissue Doppler isovolumic contraction time, tissue Doppler ejection time, and myocardial performance index values compared with patients who were vitamin D non-deficient. On Pearson's correlation analysis, Serum 25-hydroxy vitamin D level was significantly positively associated with LDL cholesterol and significantly negatively associated with left ventricle mass index, myocardial performance index, and left ventricle internal diameter. The relationships between 25-hydroxy vitamin D with myocardial performance index and left ventricle mass index are shown in figures. Multivariate linear regression analysis showed that 25-hydroxy vitamin D was independently associated with myocardial performance index, left ventricle mass index, and LDL. For the discussion, the main findings of the study were that patients who were vitamin D deficient had higher creatinine value, parathyroid hormone level, myocardial performance index, and left ventricle mass index, and lower total cholesterol and LDL compared with patients who were vitamin D non-deficient. And serum 25-hydroxy vitamin D level was independently associated with myocardial performance index, left ventricle mass index, and LDL values. The study findings confirmed the hypothesis. Recent clinical studies show that low levels of vitamin D are associated with hypertension and cardiovascular diseases such as myocardial infarction and congestive heart failure. The antihypertensive effects of vitamin D include suppression of renin and parathyroid hormone levels and renoprotective, anti-inflammatory, and vasculoprotective properties. Low vitamin D and high parathyroid hormone level has been associated with clinical cardiovascular disease outcomes, including incident hypertension, myocardial hypertrophy, heart failure, and cardiovascular disease death. Left ventricular mass and left ventricle ejection fraction are both important predictors of heart function decline and mortality. Improvements in left ventricle ejection fraction have been associated with improved prognosis, and this may point to a potential role of parathyroid hormone as a determinant of cardiac remodeling. In the study, parathyroid hormone level was significantly higher in patients with vitamin D deficiency, but was not independently associated with myocardial performance index. The researchers mentioned that one of the most important reasons of the different results is the technical difference of evaluating left ventricle function. Vitamin D deficiency is prevalent in chronic heart failure and is associated with poor outcomes. And the results show that 25-hydroxy vitamin D levels were independently associated with impaired myocardial performance index. The impaired myocardial performance index has been widely used to quantitatively assess myocardial performance, and myocardial performance index is more reflective of overall cardiac function than systolic or diastolic function alone, and predicts both worsened morbidity and mortality. There are limited numbers of studies investigating the association between vitamin D and left ventricle systolic and diastolic functions, but the previous studies have controversial results. The pathophysiology related to impaired myocardial performance in patients with lower vitamin D is not yet fully clear. Calcitriol or vitamin D3 may modulate key processes involved in the pathogenesis of left ventricle dysfunction, including calcium flux and calcium homeostasis, the renin-angiotensin system, cardiomyocyte proliferation, myocardial fibrosis, and proliferation and arterial stiffness. The relationship between lower vitamin D and increased arterial stiffness is well known. Increased arterial stiffness affects both left ventricle systolic and diastolic functions. Therefore, a lower vitamin D levels may be effective on impaired myocardial performance via increased arterial stiffness. On the other hand, a lower vitamin D level is associated with increased activation of the renin-angiotensin-aldosterone system. Therefore, increased the renin-angiotensin-aldosterone system activation may stimulate myocardial fibrosis and hypertrophy, leading to left ventricle systolic and diastolic function. The present study demonstrated that lower 25-hydroxy-vitamin D levels were also independently associated with left ventricle hypertrophy. The association of lower 25-hydroxy-vitamin D and left ventricle mass index seen in this study is consistent with prior studies. Prior studies have shown a relationship between vitamin D deficiency and adverse cardiac change, especially left ventricular hypertrophy in patients with chronic kidney disease. Vitamin D supplementation is significantly associated with better survival, specifically in patients with documented vitamin D deficiency. Moreover, vitamin D supplementation regresses both left ventricle hypertrophy and left ventricle dysfunction. Thus, in this study, the researchers found an inverse relationship between 25-hydroxy-vitamin D and myocardial performance index. In conclusion, the present study showed that lower serum 25-hydroxy-vitamin D levels were significantly associated with impaired myocardial performance as well as left ventricle hypertrophy and LDL level in hypertensive patients with newly diagnosed and preserved ejection fraction. Lower 25-hydroxy-vitamin D levels may play a role in the pathogenesis of myocardial dysfunction even if ejection fraction is normal. Next, I'm going to discuss the relationship of the two articles. First, the median of serum 25-hydroxy-vitamin D in the first article is similar to the second article, approximately 14 nanogram per milliliter, that illustrates the low 25-hydroxy-vitamin D levels. Second, vitamin D deficiency affects cardiovascular diseases, for example, coronary artery diseases, left ventricle hypertrophy, and left ventricle function. Especially the lower level of vitamin D leads to increased stenotic coronary arteries in cardiac diabetic patients. Moreover, the lower vitamin D level is associated with increased activation of the renin-angiotensin-aldosterone system. Therefore, increased renin-angiotensin-aldosterone system activation may stimulate myocardial fibrosis and hypertrophy, leading to left ventricle systolic and diastolic function. Third, both articles use the Alexis vitamin D total assay or direct competitive chemiluminescence immunoassay to evaluate serum 25-hydroxy vitamin D levels. Although both articles use the same assay, other researchers mentioned that the Roche Alexis vitamin D3 assay presented unacceptable performance and thus underestimated vitamin D level. However, some results of both articles contradict. The result of the first article showed that the presence of hyperlipidemia was significantly associated with lower values of 25-hydroxy vitamin D. The hyperlipidemia was defined when the total cholesterol is higher than 200 mg per deciliter and or total triglyceride is higher than 150 mg per deciliter. On the other hand, the result of the second article displayed that patients who were vitamin D deficient had lower total cholesterol and LDL compared with patients who were vitamin D non-deficient. In my opinion, it is clear that vitamin D deficiency affects cardiovascular diseases in the elderly, both diabetes and hypertension. Lower vitamin D level associated with coronary artery disease that increased stenotic coronary arteries and is associated with left ventricle hypertrophy by increased arterial stiffness and increased activation of the renin-angiotensin-aldosterone system. Thus, I believe that vitamin D sufficiency decreases cardiovascular diseases. However, larger trials are needed to confirm these studies, and the level of serum 25-hydroxy vitamin D should be measured by other assays for accurate results. Thank you for your attention.